All right, moving on to our ICF model. If you have not talked about this in Intro to Physical Therapy yet, you will touch on this in Growth and Development. I wanted to talk about the ICF model because part of how we determine the best treatment for our patient, we need to consider the body, the whole person, and the person in society. So the World Health Organization, the WHO, developed a model called the ICF model, which is our International Classification of Functioning, Disability, and Health. We can use this model to guide, to ensure our rehab treatment focuses primarily on reversing or minimizing impairments, works on activity limitations, and works on participation restrictions. As I mentioned, you'll talk about this model a little bit more in other classes. This portion here on the right is an example of the ICF model. So essentially it talks about the health condition, how it affects body function and structure, how it affects activity, and how it affects participation. But it also considers other environmental factors, personal factors, and contextual factors. And if you notice all the arrows, they're going in both directions, meaning that limitations in activity have an impact on body function and structure, and limitations in participation are related to the health condition as well as other personal factors. So again, you'll talk more about the model specifically in other classes. However, what I want to point out here is the level at which our physical agents have a direct effect on our patient. So our physical agents work specifically at the body function and structure level. So our physical agents or our modalities, we're trying to fix a tissue injury or a structural impairment that will then impact further issues. So again, think of our physical agents as trying to work on the tissue or the structure itself. One of the things that I want you to start thinking about now is how to plan to use these physical agents, okay? So first thing we want to do is consider if the modality is included in the plan of care. So as a physical therapist assistant, you cannot do anything that is not within your patient's plan of care. So that's the first thing we have to do, is look to see if physical agents or modalities are listed there. If they're in the plan of care, the other thing we want to consider is the stage of healing of the tissue that is involved. I often call this our target tissue. So what stage are they in? Is this an acute injury? Is it a chronic injury? Is there inflammation present, or is there a lack of blood flow? That will then help determine which physical agent you may consider using. Even if you think you're good to go, the next thing we have to consider is our precautions and our contraindications. So this is basically determining, is it safe for this specific patient to use this type of physical agent? Are there other things that we want to talk about? And on the next slide, we'll talk about what precautions and contraindications mean. Remember, we also want to consider, is there an active alternative type of treatment? As we looked at in the last couple of slides, the APTA is really stressing an active intervention with our patients. So is there an active alternative that is much better? Because we want to use our research-focused treatment first. And when it comes to our contraindications and our precautions, a contraindication is a condition under which a particular treatment should not be applied, and we also refer to this as an absolute contraindication. So let's say we wanted to use a hot pack on our patient, and the area we want to use it on, there's a big open wound and it is bleeding. That would be a contraindication. We do not want to put our hot pack on an open wound that is bleeding. That is an absolute contraindication. Now, a precaution is a condition under which a particular treatment should be applied only with special care or limitations, and we often refer to this as a relative contraindication, okay? So this could be something where maybe the patient has an open wound on their foot, but we are treating their shoulder, okay? So we know that they maybe have excessive bleeding, but not in necessarily the area that we're treating. So we want to be careful to make sure that we aren't causing any additional issues or impairments with our hot pack on their shoulder because of the open wound that they have on their foot. Some examples that we might consider for precautions and contraindications: open wound is definitely one, an infection is definitely another one to consider, a blood clot is something to consider, and even things like lack of sensation. So if you go to put a hot pack on someone's shoulder and they don't have sensation there, they're not necessarily going to be able to tell you what the modality feels like. Some relative contraindications may be things more like nausea, vertigo, or hypersensitivity. So we may be able to still use our treatment, but we might have to modify it. Again, some more general contraindications. So these are typically a good rule of thumb to kind of consider when using your physical agents. I would say the ones listed on this slide are either contraindications or precautions. Remember, that's our absolute or relative contraindications. Pregnancy, the issue with this is that if the physical agent, if the effects of it could potentially reach the fetus, that is a problem because we do not know the long-term effects of some of these modalities. So pregnancy is a general contraindication, something we either want to make sure we do not use our modality with, or maybe we need to alter or modify or limit what we're using. Malignancy, again, so if there is a malignant tissue, we want to make sure our physical agent doesn't alter the tissue or the circulation to that tissue. Again, some physical agents have been known to accelerate growth or metastasize this malignant tissue. A pacemaker or other implanted electronic device. Some of the energy from our physical agents could affect the function of the device, which could then adversely impair our patient. As I mentioned, impaired sensation. The biggest thing with our modalities is that we ask our patients, how is it feeling? If they can't feel it because of impaired sensation, we can't safely use that modality. And impaired mentation, I think of this as cognitive impairments. So if they, again, can't communicate how they're feeling or how they're doing, it's not necessarily safe for us to use this technique. The general effects of our physical agents include modifying tissue inflammation and healing, relieving pain, altering collagen extensibility, and modifying muscle tone. And we're going to talk about these 4 different components. So let's say that we start with an injury. Let's say you slice your finger or you scrape your knee. The first thing that happens after we have our injury is we see this inflammatory process. Okay, followed by the inflammatory response, we see our proliferation, where our body is trying to heal and fix the injury, followed by our maturation, where we are remodeling and finalizing and healing the structures. We will talk about these phases a little bit more in detail in our next lecture. You'll also talk about this in anatomy and physiology and pathology. So some of those things that we've mentioned can be impacted differently by our different agents. So our thermal agents, the biggest thing we see with our thermal agents is we're changing the circulation, the chemical reaction, and we're altering the collagen extensibility. Remember, thermal agents can be cryo or thermal, okay, so they can be hot or cold. Our mechanical agents, we're controlling motion and altering fluid flow. Remember, our mechanical agents can be our compression, our traction, we can use water or sound. So we're controlling motion either by limiting it or increasing it, and altering fluid flow by either increasing the movement of fluid or preventing the movement of fluid. Our electromechanical agents are going to alter our cell function, and remember, these are our electromagnetic fields or our electrical currents. Pain relief. So pain is an unpleasant sensory experience that's either associated with actual pain, perceived pain, or potential tissue damage. Okay, so keeping in mind that even though there may not be a structural problem, patients may still report pain. And pain is there to protect us from further injury and further damage. However, when pain is out of proportion of the extent of the injury, or if it persists for a long period of time, it can interfere with normal activity, and it can cause functional limitations and disability. So we use our modalities to modify pain transmission within the peripheral and central nervous system. We can change the sensation at the site of the injury, or we can modify muscle tone. At the cellular level, this is occurring because we are modifying tissue inflammation and altering collagen extensibility. Now, acute pain. Acute pain is usually from a new injury in a very short time frame. That time frame is a little bit variable, and we'll get to that more in our next few lectures. But the goal of treatment for acute pain is to control the pain and inflammation and prevent exacerbation or worsening of the pain and those other symptoms. The physical agents that we often use are going to be our sensory level E-stim, which is our electrical stimulation, cryotherapy, as well as low-level laser light therapy. The way that this works, our sensory level electrical stimulation, it modifies the transmission at the level of the spinal cord or stimulates the release of endorphins within the body. Our cryotherapy, again, is thought to modify, again, the transmission of pain signals to the spinal cord by either slowing it down, blocking the nerve conduction, or by controlling inflammation. Chronic pain, this is pain that does not resolve within a normal recovery time. Now, normal is all relative. Every person is different. By definition, we typically say chronic pain is pain that lasts more than 6 months. However, again, that is going to be variable. With chronic pain, the underlying pathology is essentially healed. So the goal is to more focus on promoting function, enhancing strength, and improving patients' coping skills. And there's definitely going to be a psychological component to chronic pain. Some of the physical agents that we may use will be water or hydrotherapy. This type of environment usually allows patients to be more active in the water than on land. The effective buoyancy of the water and the temperature can be very beneficial. We'll often use motor level electrical stimulation to increase muscle strength. Collagen extensibility. So we said extensibility is increasing the elasticity or increasing the length of the tissue. And oftentimes after an injury, those supportive connective tissues become shortened due to immobilization because of a cast or a sling or a splint, or because of disuse, so people are afraid to move that body part. So what happens is that the collagen tends to shorten over time, and it can limit range of motion either because it's painful or because the patient is guarding or avoiding moving that part of the body, or there is some type of internal derangement, which would mean some type of structural deformity. Something is blocking the movement within the tissue itself. So tissue can be stretched actually back to its normal length to restore range of motion and restore function. And the way that we do that is through increasing temperature. So you can see as the temperature increases, so does the collagen extensibility of our tissue. Last thing I want to talk about is muscle tone. So muscle tone is the underlying tension in a muscle, and we all have muscle tone even if a muscle isn't firing. So by definition, muscle tone is the underlying tension in a muscle that serves as a background for muscle contraction. You can also think of it as the resistance to passive elongation or to passive stretch. Pain may cause change in a muscle tone either by increasing it or decreasing it. So if the tone increases to protect a body part or splint a painful area, we're going to see hypertonicity. So tone will increase. The tone may also decrease as a reflexive response to pain, and we have hypotonicity. Muscle tone can also decrease after surgery. So we tend to see a decrease in muscle tone with trauma. But every patient is a little different. You may see a different response. So how can we fix this? Hypertonicity, so directly we can alter the warmth of the tissue. So we can do kind of a neutral warmth, or we can do a very prolonged cryotherapy over time. We can also affect this indirectly by stimulating the antagonistic muscle. So the muscle on the opposite side of the injured area will help to decrease the muscle tone. With hypotonicity, we want to increase the muscle tone. So we can do this by doing a quick icing or use our motor level electrical stimulation. So the last slide I want to end on is, again, planning for use of the physical agents. So we've already talked about all of these things to consider, but we need to make sure that we have ruled out any of our contraindications or precautions. We've determined the stage of healing. We've done our visual examination and our sensation testing, and we've decided that there isn't an active alternative that's better than what we want to use with our physical agent. So kind of the next step of what we're going to be doing in lab, we are going to move on to sensation testing and visual examination to make sure that we know what stage our wound is in and that we know that it's still safe to use it. So ruling in our precautions and our contraindications, and also helping us figure out the stage of our injury, whether there is swelling or inflammation present.